Good evening. Thank you for coming out on a wonderful Monday night in Sydney. It would be much nicer sitting on your back deck with a glass of wine. However, we'll do our best to keep you entertained for the next couple of hours. We're also streaming via YouTube, so no profanities, nothing untoward because it's going out to the web, all right? So we're all going to be very good little Vegemites. What we're doing tonight is we're going to start with Simon Hanna from our national office, who I'll introduce you to in a moment. And Simon's just going to give us an overview of what has happened in the last couple of months. And then we're going to go to a panel. Now, these panels are about as good or as bad as you want to make them. If you're engaged and querying and quarrelsome, belligerent even, it'll work really well. If you sit there like stunned mullets, we'll be out of here by 7:30. So, depends which way you want to play it, entirely up to you. We've got some scenarios, but it'd be much nicer if you threw questions and challenged our esteemed colleagues up here. That's the way it works best. Okay, let's start with Simon. Simon has very graciously flown up here from Melbourne for our national office. Simon Hanna is an optometrist with about 12 years' experience. He's been a lecturer at Melbourne University and is now the clinical policy advisor to Optometry Australia in Melbourne. Simon has been up to his armpits in this entire Medicare process since the government first mooted it, and has probably had more to do with Medicare than he really cares to remember. He's going to give us the overview, just fill in the blanks, make sure we're all on the same page so that when we start discussing, we've all got a common base of understanding. Please welcome Simon Hanna.
Thank you, Andrew. Good evening, everyone. Thank you for having me here today in Sydney. Sunny Sydney as it is. Just wanted to say first good evening to my fellow panellists, and Joe and Malinda and Nick and Steve. As Andrew said, my name is Simon Hanna. I'm the Clinical Policy Advisor at Optometry Australia, our national office. And just to kick this evening off, I just wanted to start with a brief introduction and an explanation as to what some of the changes to the Medicare benefit schedule was for optometrists and how that's impacted on our profession and us as practitioners. So in 2014, the federal budget included measures that impacted on the provision of optometry services under the MBS. As most of you know, these changes came into effect, most of these changes came into effect on the 1st of January, and they include things such as the fee cap removal, the change in the comprehensive eye examination items and accessibility to those items, including age groups and the time interval with which they can be accessed. The MBS indexation freeze announcement came out shortly after that. A reduction in optometry fees by 5% was also announced, as well as a flow-on effect to the DVA's optometric schedule, which we'll touch on very briefly. So we'll just go through each of these changes. So as Andrew said, this is mainly a factual presentation. Some of the things that are also included in here are some of the frequently asked questions that come across our national office desks, phones and emails over the course of the last 6 to 8 weeks. Perhaps we can answer some of the confusions or misconceptions around the schedule and some of the grey areas that we can seek to clarify. And before I finish up, we'll sort of touch on some common sort of multiple billing scenarios as well. So the fee cap removal. This change came into effect on 1st of January 2015, and it provides optometrists with an opportunity to determine the fee that they deem most appropriate to charge their patients for their clinical services. Now, this by no means means that you have to privately charge or charge above the rebated fee. Depending on your mode of practice, your scope and your demographic, you're more than welcome obviously to bulk bill a portion or all of your patients as you have been. Some of the questions that we've been asked include whether or not optometrists can charge a gap payment or a co-payment, as has been bandied around as the GP suggestion was. The answer is no. You cannot bulk bill and charge an out-of-pocket fee for the same consultation. However, the proviso to that is that you can charge a separate fee for clinical services not included or billed for in the schedule. Now, I've obviously only put on a couple examples up there in OCT and digital retinal imaging. You can fill in the blanks, and the list is as long as you'd like it to be. and we perhaps can discuss some of those options today as to what constitutes outside the schedule and what doesn't. There is no maximum that has been limited on optometrists to be able to charge outside of the scheduled fee. Given that, let's talk a little bit about what are some of the billing options that are available to optometrists since these changes have come into effect. One of the first options is that you can charge your patient the full amount. You provide them with a receipt clearly showing the date of the consultation, the item number, and the amount charged, and the patient can receive their rebate from their local Medicare office. One of the advantages to this is obviously you secure your payment regardless and irrespective of what the patient's rebate and what they're entitled to as a rebate. Medicare Easy Claim seems to be one of the most popular ways in which billing is now occurring. You do not need a secure internet connection or practice software for this. You just need your HiCaps terminal with which you're able to swipe the patient's Medicare card. And you can also charge an out-of-pocket fee, or what you'll need to do is actually charge the full amount and then swipe the patient's Medicare card in order for them to receive their rebate almost instantly. Whether you choose to bulk bill or the patient receives their rebate directly from the HiCaps terminal, both of these options are accessed. The rebate is accessed almost instantly. One of the limitations, however, on the Medicare Easy Claim is that you cannot charge a DVA patient through Medicare Easy Claim. The system is not set up as yet for that. The third option is Medicare Online. This does require an secure internet connection and the practice software to be compatible. However, you can also claim DVA for this, and this is the third most common way with which practitioners are now billing. The time interval changes to comprehensive eye examination. So we used to know the item as the 10900 item. The change to this item came into effect from the 1st of January this year. For people under 65 years of age, the item is now 10910, and the allowable time frame for a rebatable comprehensive examination has been extended from 2 years to 3 years. For people 65 years and over, so inclusive of 65 years of age, the item is now 10911, and the rebatable comprehensive eye examination time frame has been reduced from 2 years to every 12 months. Just to put this into perspective with a very quick example, if your patient was billed a 10900 on the 1st of September 2014, this is considered the start of their comprehensive eye examination clock. So if they are under 65, they are now eligible for a 10910 on the 1st of September 2017. If they are 65 years of age or over, they are eligible for a 10911 on the 1st of September this year. If the patient was 64 when they accessed a 10900 on the 1st of September 2014, and sometime this year they turn 65, they are eligible for a 10911 on the 1st of September this year. The 10916 and 10918. Before we discuss either of these items, it needs to be noted that neither of these items have changed in their item descriptor title or their item descriptor details. Both of these items are essentially what they were since the 31st of December 2014. Nothing's changed to either of these items. What Optometry Australia has sought to do was to seek clarification on when and how to use these items, the intent and the appropriateness of the use of these items. So I'll attempt to do that very briefly in the next few minutes. The 10916, as the title of the item suggests, should be used as it is, which is that it is a brief initial consultation, first in the course of attention of not more than 15 minutes. Now, historically, this item has been used for patients that have presented with any number of acute, subacute or chronic conditions that have taken less than 15 minutes to assess, diagnose, treat and manage appropriately. For example, not that this is an exhaustive list, but some of the conditions may include allergic or viral conjunctivitis, epilation, any sort of contact lens, corneal abrasion or a stye. There are obviously a multitude of other conditions, but these are some of the conditions that you may have in the past used a 10916 as a appropriate billing item. This continues to be the case. The 10918, the subsequent consultation, second or subsequent in a single course of attention for a clinically relevant service to the needs of patient. Optometry Australia has endeavoured to seek clarity from Department of Human Services, from Medicare, around when and how this item should be used. The information that we've received is that there's two main uses for this item. One being that the 10918 can be used as it has historically been used, and that is when a patient returns for a subsequent visit associated with a comprehensive examination just beforehand. So within days or weeks of the comprehensive examination, you've asked your patient to come back for anything from a dilated fundus examination, IOP recheck, red eye review, therapeutic prescription review. Again, the list goes on, that's not exhaustive, but for any of these subsequent consultations associated with a previous comprehensive examination, within days, weeks or so, this is the item that needs to be used. In addition, the 10918 can also be used, according to the Department of Human Services and information we've received at Optometry Australia, for a comprehensive examination or a reassessment if the patient has returned within 3 years and they are ineligible for any other comprehensive item. So Medicare has advised that if a patient returns before 3 years, presuming they're under 65 of course, they returned within 3 years and they're ineligible for a 10912, 913, 914 or 915, the only appropriate item to use would be a 10918. With regards to the phrasing around the course of attention or a single course of attention, again the Department of Human Services has advised that the best way to interpret that, or the most appropriate way to interpret that phrase, is to consider it as an episode of optometric care. So, for example, at the 10918, a subsequent course of consultation would be the second, third, fourth, fifth, however many episodes of care within 36 months. And that's where the phrase second or subsequent course of consultation. Now, there may be different interpretations, alternative interpretations, but that is what we've received from the Department of Human Services. More good news, the MBS indexation freeze. The indexation freeze came into effect in November of 2013, and we've been advised it will continue until at least July 2018. This means that the scheduled fee for MBS services will not rise as in previous years, in accordance with an indexation price determined by the government. What does that mean for us? It means until at least the middle of 2018, the 85% of the scheduled fee will be the same dollar figure as it is at the moment. So, for example, for your 10910 or 10911, it would be $56.80. Reduction in optometry scheduled fees by 5%. Now, again, there's been a little bit of confusion around, was it exactly 5%, was it less, was it more? And myriad of different computations and calculations have been attempted. The 5% reduction came into effect on the 1st of January 2015, and this was in addition to the MBS indexation freeze. Let's go through the maths very briefly. The government did not directly reduce the full scheduled fee from 85% to 80%. What they did do is they took the 80% figure that it would be. So, for example, the full scheduled fee was $71. They took 80% of that, so that was $56.80. And then when they wrote the new schedule, they ensured that 85% of the new full scheduled fee was $56.80. That is how they got the $66.80 figure for a full scheduled fee for a comprehensive examination. More than happy to go through that again throughout the night. If anyone's confused, come and find me afterwards. But it is 5% that they did reduce from the original $71 full scheduled fee. And as I've got written there, the end financial result is the same regardless of how you do the maths. What sort of effects did this have, all these changes have on the DVA's optometric schedule? Well, the indexation freeze that was imposed on the Medicare benefit schedule rebates is also imposed on the DVA scheduled fees, but only for consultations. The freeze does not extend to the optical appliances prices. No, according to DVA agreement that we have, you cannot charge a private billing of DVA patients. So the full scheduled fee, which is 100% rebatable, is what the practitioner is entitled to. And as I've written up there, the full scheduled fee reduction did not apply to DVA patients. So it is still $71. It is not the $66.80 that we have for the Medicare benefit schedule. One of the other major changes to the DVA schedule is that depending on the veteran's age, they can access the comprehensive examination, the 10-9-10 or 10-9-11, as with the Medicare benefits schedule. So it's 3 years for those under 65 and 1 year for those 65 years or over. And that did come into effect from the 1st of January 2015. As I said, I just wanted to wrap up with a couple of multiple billing inquiries that we are getting across our desks and emails, and quite a few members have queries around this. So very, very simply in table format, when you bill a 10940 or a 10941 visual fields, bilateral or unilateral items, you cannot bill a 916, a 918 or the domiciliary items. Anything to your left can be billed in conjunction on the same day with a visual field item. Low vision and children's items, similar story. Anything on your left there can be billed. A 916 and the contact lens items cannot be billed in conjunction with a low vision or a children's binocular assessment item. Again, that was just the factual presentation just to kick off the evening. Some of those issues will be explored further, I'm sure, and others they're quite clear cut, and that's the schedule. As I said on a number of occasions, as we have been advised from the Department of Human Services to interpret as they're written currently. Thank you.
Simon, thanks. Let me just introduce the panel to you at this point, because this is where we kind of get into this discussion. Simon, you've met. Steve Zantos. Now, Steve Kwok is the current Medicare advisor, but because of Medicare's approval processes, we didn't apply in time, so Steve was unable to be with us. But Steve Zantos generously agreed to step in, and he's had a great many years as a Medicare advisor. So, Steve, thanks for your time. Nick Papadopoulos, private practitioner out at Parramatta. And we're going to be picking Nick's brain about a couple of other issues later on, but also about some of these billing issues. Malinda Halley from the Illawarra, is it Shell Harbour? Dapto in the Illawarra. Again, Malinda has made some changes to her practice around billing, which I want to explore later on, but also around the item numbers. And of course, our mate at the end, Joe Chakman, who has been with us for a great many years, probably more than Joe would care to admit, but has probably forgotten more about Medicare than any of us have learnt. So, Joe, thanks for coming up tonight. All right. I just wanted to... I'm just going to... pause that and go to... Here we are. What we did was we ran some scenarios based on the calls we got through the office. And Joe, I said to Council the other night, Joe basically hasn't hung the phone up for the last 2 weeks. He was considering a phone graft. So these are the calls that we're getting. So some of them will possibly repeat some of the stuff that Simon has put up, and if that's the case, we'll skip through them very quickly. Others might help to clarify the sorts of issues that are coming up. But at any point, if you're asking, if you want to ask something, if you want to query something, please do so. Now, there's a roving microphone. If we don't get the microphone to you, that's all right. Ask the question, I'll repeat it so that the people on webinar get to understand the context of the answer. And panel, if you're answering, if you could make sure you speak into one of the microphones, please, again, for the webinar. Okay. Any questions for Simon or anything else before we dive into some of these scenarios? Just grab that.
If someone comes to see me, say 25 months after I saw them, and and I suspect glaucoma or the tensions have gone up or something like that, I've got a trigger, and I want to do a visual field, what item should I charge? Because if there's no significant refractive change, but I want to check the refraction before I put the lens into the visual field analyzer, and if there's no other symptoms directed to me from the patient, what item do I charge? Because I would have thought someone coming back to see me within that period is a 10918, so that's the only item I can charge, so I can do a full test to get the fee. So what's a 913? So the 913 is significant change, or
New
yeah, but
signs, new symptoms.
it's not a new sign or symptom that's presented to me. So if I see it as a problem, that's okay.
Well, to answer that,
Joe, take the microphone over, please.
I'm sorry. You've raised a problem here, but the notes make it quite clear that visual field loss is particularly associated with glaucoma is a progressive condition. So in theory, you should be able to charge whatever one it is, 1/4, is it? That the patient has a progressive disorder. If you look at the Medicare schedule book and the definitions, if I can find it quickly, it actually says there that glaucoma is regarded as a progressive condition. So you've got someone with a visual field loss that you don't know that they've got glaucoma. Is that what you're talking about? Oh, I see. So you haven't okay, sorry, I misunderstood. Well, my own view is that, while Simon says that the Department of Health has advised that a 918 could be charged at that time, I think that's wrong. That's if you just look at the definitions, it can't be. You can't charge at any of the visual field items with a 18 anyway. So there isn't an item that you can charge. That's the reality.
So just to explore that further, if the patient didn't have a field loss, you wouldn't be able to charge the 10,940 anyway. And if they did have a field loss at that point, then you could charge the 914 because you've diagnosed a progressive condition.
So how do you determine the person's got a field loss in the first place? I mean, how can you not be paid for doing a test that's trying to determine something?
I think the schedule refers to a known or suspected. So if you've done confrontation and you think there's a field loss there, you can confirm it, which may show there isn't one with a 10940, or you could have a suspected defect of the visual pathway. I think there's something going on with the optic nerve. You run the fields and it turns out to be clean, so you know they're not that far down the glaucoma slope yet. But you don't have to have a defect to go and look for a defect. You have to have a suspicion of a defect. Would that be correct? Thanks. And I guess one other comment, when you said that the person came in 25 months for a fields test, I guess there I would make sure that the practice staff flagged that and thought, I think they need another reassessment, and then the optometrist will redecide if they want a fields test 25 months after the last time you asked for a fields test. But then you didn't give me a full background, so that's just me interpreting what you said the first time. Yep.
Can I just make the comment that one of the joys of Medicare is there's never a right answer?
Can I just add
That's
to
why there's a
too,
panel of 5, because that way we get 6 opinions.
It doesn't have to be 25 months. They can come back to you 6 months later. It's not. That same applies.
Tom.
Sorry, I'd just like to comment on the gentleman's remark there. I think he's faced with the dilemma of what to charge, a 10918 or a 10940. So for example, if someone says, I want to get new glasses, and it's been about a couple of years, right? Well, obviously you can check the prescription. It's a good way to check the prescription to make sure you give them the right glasses. So if you check the prescription, then obviously you can then charge a 10918. But let's say the pressures were a little bit higher this time than they were last time. You're thinking, this guy could maybe have glaucoma. So I'll do a visual fields test. So you do a visual fields test. And then you're faced with the dilemma, I can either charge a 10918 or a 10940. So I think the question was, which one do I charge?
As the boss at my practice, I would say don't charge the 8. In this scenario, you've got more than one option of things to pull out of the Medicare bag. You're not obliged to grab the 8. You're allowed to use the 14, and you're allowed to tag that with a 40.
Okay.
Yep. So you're not obliged to pick the lowest item number. You've got more than one option in that case. For example, you've got a change intentions, which means really you've got a 4 or a 3, but you don't have to pick the lower one because it exists. Yep.
Could I also add, though, that you don't have to charge a consultation. You don't have to charge a consultation item to charge the 40. You just can't charge it in association with certain other items. So you can charge any of the visual field items on their own. You don't have to have a consultation item to go with them. And then, I know it. What you have to do if you want to charge a fee is a private fee, is my view.
Well, basically, if you want to do the right thing by the patient and do a good visual field test, you want to make sure they can see that fixation point at the end of the dome. So you've basically got to do a test. So you're spending time doing a test, and then you're spending time doing a visual field test. So I've just not really known. I've actually, we have been knocked back on a 918 because I thought that was the right thing to do.
No, you can't charge a 918. As I said, my view is you probably can't charge anything except in special circumstances, along the lines that Malinda was talking about. But, what we're really coming back to here is that the government is trying to force not only optometry but medicine as well into charging additional fees to discourage patients from attending if they can, and secondly to reduce the costs to the government. So that's known. It's maybe an artefact that they didn't mean this to happen, but it's certainly something the government would be quite happy about. They want you to charge a private fee. Now, I think that there is one thing that everyone needs to do is to establish some sort of policies for their own practices on who they bulk bill and who they'll charge private fees for and the circumstances that they'll charge them in. You can decide that you're going to bulk bill everyone, that's fine, but you're going to finish up at times severely financially disadvantaged. Most people, I think, will need, if they want their business to continue, to find some sensible way of determining which patients they'll bulk bill and which patients they won't. I think that's the reality. The government is forcing you to do that.
I have a slightly different take. In your example, you mentioned that the person has shown up 25 months early. I suspect from that you mean that they've turned up on their own accord. Now,
25 months after I saw them. So in the
yes, I'm assuming that they have turned up before you have recalled them. So therefore that's implying that they have noticed something or they're bothered by something. So if someone came in to see me today and they've come in before I've called them, my assumption is they have something wrong. They've got some issue that they want addressed. Now, you also mentioned that you saw something like pressures were a bit higher, or you thought there was a bit, optic nerve head had changed. There's a 913. So the second scenario is you have seen new signs. You have seen that the optic nerve head is a touch different. You've seen that the pressures have gone up a bit. 913, then you could do your 1040. The third possibility is that you just do a 10940 and you charge them a much higher fee. You don't have to charge them $63.75. You could easily say to yourself, I'm going to do a refraction on Mrs. Smith so I can get the right script before I do the visual field. So instead of charging her 63, I'll charge her 90, and I'll tell her that, Mrs. Smith, because the guidelines are such, I'm going to charge you $90 to do the visual field test. So you have a lot more options now than what you did before. You don't have to find another item number and charge exactly what the schedule says. No.
You can charge $90 for the fields, and Mrs. Smith may either be...
Yeah, you can't get it back. It's correct.
No, you have to speak right into the microphone, please.
Yes, they can't get it back.
They're not eligible for any rebate on that, correct. Yeah, so you can charge whatever you like now with the fee cap removal. Gave me a dodgy mic, Andrew.
This one works.
Someone heard that. Can you hear me now? Excellent. So you can charge any fee you like for any consultation, and whatever eligible rebate the patient will receive. And as Nick has rightly said, you can charge $90 for a fields, and they'll receive their 60, whatever it is.
Can I say that I think Nick has summed it up pretty well. First of all, it's an excellent question. It points to a bit of a kind of a weakness in the system, but it does have a way of dealing with it. And I think the way to approach it is to not try to determine before you've done the consultation what item numbers, might apply here, because that can get you into all sorts of confusing situations. So the thing to do is to say, look, what's the right thing to do for the patient consultation-wise, and when I've done all that, then I'll, figure out what the item numbers are. The caution you need to have is that in this particular scenario, one of the choices is that the patient isn't eligible for a rebate from computerised perimetry, in which case you have the option, as Nick has said, of charging them. So it's obviously better for the patient to know that beforehand. So in the case you've given, you've got a patient where you suspect they've got they're on somewhere on the scale of a progressive disorder, and that you may at some point, need to do perimetry and a bunch of other things. So I think because whether you recalled the patient to come back or whether they came back of their own volition before the 36 months, I think you do your history, you go through the consultation, explain to the patient you want to do perimetry, regardless of whether they're eligible for a rebate or not, and let them know what the options are. But as Nick has said, if in the course of the consultation, the examination, you found that something else has changed, like the optic disc appearance, because if it's a glaucoma suspect, then clearly you're going to want to review the disc. So if you do see a change in the optic disc appearance or something else, intraocular pressure, whatever it happens to be, then as Nick has said, you've got a new sign that now warrants the use of a comprehensive consultation item. And of course the perimetry can tag along with that for the patient to get a rebate. If you don't find any new signs or symptoms, then the only item you can use is a 918, because the patient has just received a comprehensive exam, let's say, but it's still a review visit on that's subsequent to the previous comprehensive exam they'd had 25 months ago. So you're stuck with a 918, and you can't bill Medicare for the perimetry. But if you'd warned the patient beforehand that you have to charge them a fee for that, well, then you can go ahead and do that. So it takes a little bit of thinking ahead, but it can be managed within the scope of the Medicare system.
I guess there is one other possibility that I've just thought about. If you're a bulk billing practice, you could always say, Mrs. Smith, you can come in tomorrow and have the perimetry done, because I cannot do these two services on the one day. I can only do a little refraction today. If I do the perimetry today, you're going to be whacked. But if you come in tomorrow, you're entitled to the full claim. So for those people who are really tight, there's the other option.
Hi, I'm just wondering if I understood that correctly. If someone has shown dodgy discs, shall we say, if someone has shown dodgy suspect discs at their visit 25 months previously, they can't have a 10940 billed within 3 years?
Well, we're talking, the example I gave was new signs or symptoms, which would be a 913. So if they hadn't shown a suspicious looking disc previously, then the visit you're doing today has disclosed a new sign. Mm. So that would justify starting a new course of attention. So you have to think of it in terms of a course of attention. All of a sudden they've got evidence of glaucoma. I'm now going to start a new course of attention. The previous course ended, so the 913 is appropriate. But if there is no new sign or symptom, then everything you've done is simply a review, and it's subsequent to the previous examination they had with you.
So no 10940 within 3 years?
Well, they've made the interesting point.
Hmm.
I think the point that Nick made that I think is very pertinent is that why would you do the 4.0 if you didn't have a new sign or symptom?
Because when we see a disc that looks suspect, we don't trust these people not to suddenly go offline on us.
Well,
you know.
they suddenly
and 3
got a
years
new
is a
disc.
long time.
No, but they didn't have a disc before.
No, they did. But they,
in the example that was given,
oh,
so
in my
they've got
example,
a change
they,
in their disc.
yeah, in my example they do, Joe. So I'm just moving on from that.
Well, then they've got a new sign or symptom.
Well, no, because we knew about it 25 months ago. We just want to keep a watch on them because at that stage they didn't show a defect.
Well,
But
in that situation, which is a very good example as well, it's progression of a known problem.
We're looking
So
for it anyway.
if the disc appearance has changed, gotten even worse than when you last saw them, then, as Simon has just said, the correct item would be a 914.
So just to add to that, Steve, even if there is no change, even if there is no change to the discs and the suspicious discs that Narelle was talking about, if they are still suspicious 25 months later, then they can still access that 914 because it is a progressive disorder.
The problem is that we're dealing with hypotheticals here, and that's when, if you can actually give an example of an exact patient, then you can give a better answer. But all the answers that have been given tonight, I think, are right. It depends on the patient's presentation. And the one thing that I hadn't occurred to me before, but from the question, was that why would you do fields if there wasn't a new sign or symptom? And that sort of applies still with modifications for the situation that you described, which you could you charge a 1.4. In one case, you just charge a 1.3, and at the other case, you charge a 1.4.
Well, I'm certainly not going to be doing fields if I'm not getting any money to sit there and do it. It's a very boring job.
I'll just make a very quick comment. Simon said that you can keep using 914, and technically could be yes, could be no, provided that what you're doing at that attendance is starting a new course of attention. So it's not sufficient that the patient has a progressive eye disorder that you can use a 914 every time they turn up. It's only the case if you're starting a new course of attention. So that means doing something different for the patient.
Yeah, so the wording of the 914 says that if you are doing a comprehensive reassessment of the progressive disorder. So as Steve rightly pointed out, if they just present with that progressive disorder and you're doing nothing to reassess it, then obviously no, you can't charge the 914. If you're conducting a comprehensive reassessment of that progressive disorder, then you can.
Just a quick question. With the 10940s, can you bill for, say, a 10914 after the fact of doing a field? So say someone comes in, they've got an optic neuritis or something, everything looks nice and clear, but they're saying, oh, there's the centre part of my vision and it's blurry. You do a field, there's a field defect. Can you then bill the 1.4 if they're like a first-time patient seeing you? Because you've gone and checked through everything else looks nice and clear, and then you find the field defect afterwards.
Can I ask what item number you did when you decided to do the fields?
Well, that's what I'm asking for. If you decide, look, this patient, something looks
suspicious.
suspicious.
On the item numbers until you're done for the day.
Oh, okay.
Yep. So you don't have to think, right, never met you before, you're getting a 4. You don't have to decide that ahead of time. At the end of your consultation, which may or may not include your fields, you then know what item number to use. But if they've got MS and they're complaining of fuzzy vision, it's a 1.4 and a 4.0.
Cool.
Yep.
The other thing I wanted to ask is what by Medicare constitutes a field defect? Is it just like one spot that's missing, or does it have to be registered as like a repeatable field defect?
Well,
as your colleague,
well,
I would
it's
say that
very
the field
easy
defect
because
is there.
The Medicare schedule doesn't get into that sort of detail. It's whatever your colleagues, your peers would consider to be a reasonable thing.
So if the patient, for example, has said, you're fuzzy, and you say, am I fuzzy? And they say yes, there's a central defect. That's okay. Particularly if they've got MS, because you know that there's going to be a defect of their optical pathway.
Assuming it's not a refractive error that's making you fuzzy.
Yep. Which you would work out at the end of the exam. Yep. Excellent.
Joe, this is to you. Can we backtrack a little bit? You were saying Medicare is trying to make us charge a private fee, and now that fee has been eliminated by the doctors. They don't have that, and that was coming in June. Why have we had these things thrusted on us in January?
Well, no, that's not quite right. The doctors still charge private fees. I mean, when you go to your GP, I'm sure you're paying a lot more than you get back from Medicare.
But the co-payment has gone.
It hasn't gone through, but they're looking
No.
for other ways of handling that situation. So it's not as if, they're trying to avoid getting at the doctors at the moment. The government's been stymied by the Senate, so that hasn't happened. But it doesn't mean to say that they're not trying to make it happen. It's not just optometry. We haven't been targeted in any way.
And will this go through the Senate for us as optometrists?
It's gone through. It doesn't require any further approval.
Okay. Thank you.
Hi, I've just got two little questions. Number one, if you wouldn't mind touching on a 10907, which you didn't do earlier on. And
Yep.
that's Simon. A 10918, can that be applied in a third year or not? I recall something had come across my computer that a 10918 cannot be used in a third year.
In the third year? No, I don't think that's appropriate. No, you could do the 918 up until 2 years, 11 months and 29 days, yeah.
Okay, and just my last question. How many 912s, 3s, 4s can be billed as a percentage of 910s before alarm bells start ringing? No, it's a serious question because there's got to be an answer to that one.
Yeah, well, look, no, that's an important question. The comprehensive item numbers 912, 13, 14 and 15, on average, averaged across all practitioners in the country, make up about 12% of total services. So if you have an average practice in terms of Medicare statistics, and you render 2,000 Medicare services per year, 12% of those 2,000 will be those comprehensive reassessment item numbers. And you can get a feel for these by going to the Medicare website and looking up provider percentile charts, and it'll tell you what number of items fall into the 25th percentile, the 50th percentile, the 95th percentile. So you can see if you're rendering more than, say, the 95th percentile, then obviously you're at higher risk of getting a phone call to ask you, what is it about your practice that has that unusually high number of comprehensive reassessment. So that's one thing that would trigger a call. If you're one of the top users of a particular item number, every item number, obviously there's a table of data that shows who the top users of that particular item number are. So if you're one of the top 50 users of item 912, not as a percentage but in actual number of services, then there's a reasonable chance that you could get a call asking you to explain what is it about your practice that makes that happen. So that's a second way that you could be contacted. Those are the most likely things that could trigger. But to your original question, as a percentage, if you're just looking at one item number, the 912, if you divide the 12% figure I gave you by 4 item numbers, so if maybe you're more than 3% of your total services are 912s, that would put you in the 95th percentile, possibly.
Steve, so that just makes, I think, a lot of us worried as to how we're going to bill. We might have a legitimate billing item, but might end up somewhere in the 95th, 96th percentile, and suddenly we've got to
worry too much about that. I think you should always bill what you think is the appropriate item for every patient that you see. Don't ever think, oh gosh, I've used that item a lot, I think, and so I better find something else to use. I think that's unnecessarily, worrying about the situation. But your practice management software should give you an idea of your distribution of the Medicare item number, so you can pretty easily calculate what percentage of your total services are made up by each item number. And if I can connect my iPad to this, I can show you what the average across all of Australia is, and you can see if you think you're very different to that.
Can I just make the point that you just bill what's right, and that's the answer. Don't worry about that, because you're going to have variations of enormous proportions. We've had, since the beginning of Medicare, some practitioners who specialise in contact lenses that have, virtually all their consultations are billed to Medicare anyway, contact lens consultations. What happens is someone from Medicare rings up and say, hang on, you've got a hell of a lot of contact lens consultations. They say, my business is solely contact lenses. They're checked out a little bit and the Medicare never bothers them again. Same with children's vision practices. A huge number of things related to children's consultations, particularly 1/8. After the Medicare advisor rings them up and finds out what's going on, they're not bothered anymore. So just do the right thing. And the other thing is that it would be hard to imagine in the circumstances that the frequency of 2s, 3s and 4s doesn't go up. It must go up.
Can I just add one thing to that? Sorry, Malinda. What will protect you are your clinical records. So if everything is being clinically annotated and accurately done on the day, then the professional service review won't just come and send you an invoice. They'll come and they'll look at your records, they'll investigate a number of patients, as Joe has said, and they'll make sure that everything's being done above board and to the letter of the law, and you're protected. So your clinical records are paramount to protecting you.
And just again, agreeing with what Simon's just said, under the spirit of the Medicare, you're actually obliged to have every single item number you bill. If someone pulled your record and read it, you billed it correctly. So it's not percentages or anything else. For each consultation, when you decide on that item number, if you've picked the correct one, you're fine. And so that's just, make the right decision every time and you're okay.
Can I just say, I think it is a good idea to know what your distribution of item numbers is, so that if it does deviate noticeably from, the national average, at least you can think of, the explanation. You should be aware of why your practice is different to, or significantly different to, say, national average. It's a good thing to know about your practice, not just in case you get a call, but I think you just need to, I think it's extra information that helps you understand your practice and your demographics, your patient demographics.
Where can we get that information?
Well, you can request a feedback sheet. Many people here will know that in the good old days, Medicare would automatically send that to us twice a year. Well, they stopped that because it was a costly exercise.
I requested one a month ago, Steve. They said they no longer provide that information.
Okay, well, for a while they were doing it on request, but if they've stopped that completely, then the only way you can get it is from your practice management software. And to get the national average information, like I say, I can show you on the iPad on screen later, or you can just easily go to the Medicare website and download it as an Excel spreadsheet.
Could I ask maybe Simon, we've changed from bulk billing, so we had Medicare online, and we've still got that because we still bulk bill some patients, but we charge others, so we've got Medicare Easy Claim. So that means we have to do a transaction to charge them. Then we have to do another transaction to put the rebate back into their debit card only. They can't use a credit card.
Yep.
Now, when we go to the GP, they just do it through their computer. They've got your Medicare number, and then they print out a thing which says, because your account details are registered with Medicare, they can claim, the rebate's been claimed for them. So why can't we do that? Why do we have to have our reception staff do 2 transactions to make it easier for our patients? Yes, we could tell them they can go and claim themselves, but that's not great if you've been a bulk billing practice already. It just makes life more difficult and they don't like you anymore. So why can't we do what the GPs are doing? The Medicare officer, we've spoken to several people and they say, you just can't do it. When you go into your sections, you can put yourself as a health person and a specialist and something else, because specialists and the GPs can do it, but we're not any of them.
Yeah.
We're different,
Yeah.
as we know
No,
already.
look, it's a good question, and it's one that's come up frequently from a number of different officers. I'm sure Andrew will have had a few of the same queries, and Joe. We can't do it yet. Okay, that's the short and simple answer. It is something that we are pushing for. We're requesting. My understanding is that it is an infrastructure issue. It's something that takes time. It's not something that can be done overnight, and it's something that we need to be patient with. But I think the intention is for Medicare to be able to allow optometrists to record, or for patients to record their details so that optometrists can access the patient's account and the money can go straight into there with the one transaction. As it stands, the infrastructure isn't in place for that to be the case. But that doesn't mean that it's not something that we're advocating for, nor does it mean it's something that's never going to come up and is going to happen.
Hi, could I please just ask you to clarify, with regards to DVA patients, you said that we weren't allowed to do private billing. So for instance, say we have a DVA patient who we did a 10911 and they need photos, OCT, pachymetry. Are we not allowed to charge on top of that?
I'm not sure who wants to take this. My understanding is that you can charge on top for the photos, so you are not allowed to charge in excess of the full scheduled fee, which is $71 for the consultation.
Oh, but you can charge extra items, that's
Correct.
fine. Okay,
Yes.
thank you.
I'm just wondering about the resistance to a co-payment for optometrists. Why is it such a big deal if they've actually lifted the cap and you can charge what you like? And also, if a GP co-payment does come in July, is there a possibility that there might be one for optometry as well? Because it's quite easy to explain to a patient that we've had a cut in our income by 5% or whatever to an examination. We just want you to make up that difference. And you ask them for the $5 or whatever it is, and it might be quite acceptable to a lot of patients, as opposed to charging them whatever for the examination. And that way, it just might be acceptable to both parties. And especially if the GP payment comes through, they might be expecting to do the same thing with optometry, the patients.
So again, thank you for the question. We've asked the same question of the Department of Health, and their answer is that it is simply an infrastructure issue. It is simply something that is too. It's not possible to be able to create the infrastructure to do that at the same time that they wanted to introduce the rest of the federal budget measure changes at the same time. I'm not sure whether Joe can shed any light on as to whether or not it's something that's imminent or whether it's something that's sort of long term.
I don't have any personal knowledge, but it doesn't seem very sensible to me at this stage. That's the main reason I think there won't be a co-payment. We've already taken the hit. They've reduced our fees already, and that's what they were doing with the doctors. So there's no real need for a co-payment with us. We've already suffered a hit without a co-payment. But they've given us the other side of it to make up for it, is the ability to charge above the schedule fee. So, they've taken away on one side, but they've given you back a lot on the other side. The people that suffer here are really the people, are really the poorer people in our community that can't afford the additional fees, optometrists who can't afford to charge higher fees. You know, both those parties are the ones that are suffering here. I don't think it's been a very reasonable way of addressing a financial problem, really, attacking those that are least able to handle it and people trying to stay in business to deliver a service. But no, that's my view of the whole thing. There's little that we can do about it. It's just tough luck. But the person that asked the question is right. You know, you can offset it by charging a higher fee.
Well, the co-payment would be acceptable if the lift on indexation, the freeze on indexation was lifted, so that at least there would be an annual increment. But if not, I could only see that the co-payment would have to increase, like maybe on an annual basis, in line to just keep up with inflation.
Well, we can only hope that they don't decide to introduce a co-payment for optometry. But I don't think it's likely.
Ready? Okay, I've got a question relating to item 10913. For example, if a patient has been to an optometrist recently and had his eyes examined, got glasses, and had a comprehensive eye examination, then 3 months down the road, he came to see me, and he complained of flashes and floaters and all that. Can I then charge a 10913?
No.
Because I understand that from the description, it says that the same practice applies. Now, if the patient also have other symptoms on top of the flashes and floaters,
Sure.
can I then charge the 913?
Absolutely not.
Oh, and so, not 913, 914, because it could be construed as a progressive condition of perhaps a retinal detachment.
So you can only bill a 914 when there's been diagnosis of a progressive condition, progressive disorder, pardon me. So until you've diagnosed it, you cannot bill a 10914.
Okay, say if it's a slightly different scenario where the patient, being the first optometrist, did have some flashes and floaters,
Sure.
but no other problems.
Yep.
Then when he came to see me 3 months later, he then had other problems, and I then could see that he was having a retinal tear, and could I then treat him as treat it as a 914, because it's a progressive condition from the first consultation, because he already had symptoms, and now 3 months down the road he had a tear. You see my point?
I think you can charge a 914. What Malinda said before is very, very important to remember. You don't know what you're going to charge until you've finished examining the patient.
Right, yeah.
Do you want to talk about that again?
Yeah, so I guess is the question coming, we have this in our practice a lot. People are asking ahead of time, what will the fee be and what will my rebate be? We're literally next to a Centrelink building, so we're not in an expensive area. We've got a lot of people with healthcare card holders. My staff quote the base exam fee, which is $71, and we let them know there will be 2 rebate levels, the first one or the other one, depending on whether they're healthy or what we find or what the problem is. If we're rebooking them on purpose for a review, we quote them a 10918 fee, for example. In your example there, though, I guess the question is for example, their retina is thinning and it's getting worse every year and they've got lattice and something's degenerating, would that be a 10914? I guess, do your colleagues think that retinal lattice or any other peripheral retinal disorders that tend towards tearing, is that a worthy of a 4? So that's the question there, I guess.
So I would say yes.
I would say yes.
Progressive.
Yep. Now, do you know there's a tear there when they just say they've got flashes and floaters? No. So they're going to have to risk that exam fee because you don't know what the item number is until at the end. You might give them the good news that they've just paid you $71 and they're healthy.
Because say the scenario is that he went to the first optometrist, he was told that he had flashes and floaters, but no other serious problems. Yep. Then 3 months when he came to see me later, I noticed he had a retinal tear. Yep. Okay, so that would be construed as,
Yeah, so the Medicare schedule, from what I understand, is back in the old days when they brought in 10907, that was designed to discourage doctor shopping. So when the person is swapped to you from somebody else in a 3-month period, the question there is, did the old optometrist refer them to you because, no, or did they just turn up? Then in that case, they're actually asking for a second opinion, which means you can use a 10907, or which is the lower rebate, or they may have other item numbers that apply. You might get right to the end and you say, look, everything looks great. Oh, by the way, I have diabetes. Well, you don't have retinal trouble either. And it's unknown until you finish.
Because 913 says it's at the same practice applies, but it doesn't say in 914. It doesn't say that in 914.
10914 is independent of the person or practice location.
Right, okay. So in this case, I mean, technically you can still use 914 because the retinal tear was discovered after the flashes and floaters. At
the end of the consultation, you discovered that there was a progressive condition, i.e. their retina was slowly ripping apart. You know what, myopia or whatever the reason is. And the good news is they've got a retinal tear and a higher benefit.
Well, I mean, just that it's a very sort of a grey area because the 913 has that special condition that only the same practice applies, but not the 914.
Yep. So if you've got a fresh person that's never seen you before, they're not allowed to have a 913.
Right.
And that's just the rule. Yep.
If I can explain the history of that might help. What was found with the 914s was that the low vision centres were unable to charge a comprehensive fee when someone came in with low vision. So that item was changed to remove the same location because they'd been elsewhere. They finish up at the low vision centre, be reassessed with a lengthy consultation, and then they couldn't charge. So the government changed that to make it that 1/4 different to all the others. So that's how it came about. But the same principle applies to other conditions, not just low vision. One of the things I thought was important to raise is when Malinda explained how they explain the billing in their practice, that's very important. The patient, there's it's informed financial consent's a fancy way of saying the patient has to know how much they'll be charged before you begin to give them any treatment. It's a requirement both of the Health Insurance Act and of the Registration Board. You can be deregistered for, I'm stretching it, it's in the worst situation possible, you could be deregistered for not telling the patient how much they're going to pay. So you have to find some way of telling them, and Melinda's approach is very good, saying, look, I don't know how much you'll be charged at the end of this. It could be this or that, and this is what the benefit will be. I don't know until we examine you. And when we get to a point where I think I'm going to charge you the higher amount, I can tell you if you like, or something like that, But Melinda's way I thought was terrific.
Is there anything on this side? No. It's so quiet.
What has the panel's experience been with from transition from bulk billing to private billing?
That's a good question. That was one that we were going to come to. So, Nick, I know Melinda's answered this, so I'll go to you in a sec. Have you changed?
What's your experience in transitioning from bulk billing to private billing?
My commentary was, I know what Melinda's answer is going to be, so I'll go to her in a sec. But Nick, what have you done? Have you always privately billed, or what have you done?
We ditched bulk billing back in July 2008. Our transition period was only 1 month, the month of July. We had gotten the Medicare system then, mucked around with it for a little while with bulk billing. It was a nightmare to track who got paid, who didn't get paid. Cut-off point was like 3:30 p.m. So if I saw someone at 5 o'clock, they wouldn't be on Tuesday's bill, they would be on Wednesday's bill. It was like, so I lost the plot one day and I said, 1st of July, we're out, we're done, no more, zilch, finished. So we talked about it for about a month, exactly how we're going to do it, discussing scenarios, various scripts, passed it through a couple of colleagues who had already stopped bulk billing, and off we went. I can tell you how many, did we lose patients? Absolutely. The only one clear fact that I can give you is the number of vision care patients that we have lost, because that was easy. I looked at the last 6 months of 2014, and we only had 5 vision care jobs for the whole 6 months. I looked back at the oldest records that I had kept from vision care, and that was the second half of 2008, which is just after we stopped bulk billing, and we had 20 jobs. So our vision cares have gone to almost zero. Good thing, bad thing, you can decide, but we definitely lost those people. So the price-sensitive people will go quite quickly. Resistance, you always get some resistance to payment.
And regarding payment, Malinda said your staff advised them. Are you able to advise them in the consultation room before you start consultation, or you have to, if they ring up to make an appointment, you have to tell them then? Like, what if the patient turns out and say, look, sorry, you have to pay, say, why didn't you tell me over the phone, and I came all this way?
Can you, sorry, just as you're answering that, can you start us, because you're a recent change to private, so can you take us through the story?
And I'm about 5 suburbs away from you, so hello. Yep. So I guess back in what year did we get the 07?
98. 98 it was.
I think I was about 11 at the time. So when that started, I decided I wasn't going to work for 50% off. So as soon as the 10907 item number came out, I just charged the regular fee. So if it was a second opinion and my staff, because at that stage I was renting inside an optical shop, so I had my own phone line, but I was independent as you were kind of in the old days. I had my own receptionist, I had my own phone number, and if it was a second opinion, the staff said, look, it's a second opinion, so this will be the fee and this will be your rebate, and that was kind of easy. These bulk billing Medicare changes that have come through, we kind of thought my practice isn't going to cope with a minimum 5% change in income, anything up to 20% depending on how many people come back for 918s instead of a regular fee. We've brought in kind of a 2-tiered system. I've got myself at the practice and 2 other optometrists. My name's on the door, so most people ring up and they say, I want to see her. If they see me, I don't bulk bill. So we charge a fee. If they've never seen me before, at the moment it's a $71 fee, and we've just stayed with what it was before. As I said, we're in a low socioeconomic demographic. We've got a Centrelink literally next door. We can kind of throw rocks at it, not that we do. We let them know with the rebate that it will be A or B, which is equivalent to a 10900 or equivalent to a 10907/10918. The hardest area for us has been if a patient comes back, it's under 3 years if they're under 65. We let them know you're going to pay your $71 for the exam. If it turns out that nothing's changed, there's nothing new, there was nothing wrong with you in the first place, and you're completely healthy, on the upside, you're healthy. On the downside, you'll get the level 2 rebate. And patients can then decide if they still want to see me for an exam. Now, if we've planned to see them for a review, we pre-book them for that, and we quote them the half fee consultation. So we know we're going to be doing a 10918 review. We let them know ahead of time what the fee is going to be and what the rebate will be. We actually wrote a newsletter which we sent out with the recalls. At the beginning, I had my staff ring up everybody who'd been pre-booked. They went crazy making phone calls, talking to people. We've changed over now, and we actually include a newsletter with our recalls saying, this is what's happened with Medicare, this is why we're changing our fees, these are our fee options, here's some links to the budget with Medicare, and that's now in our recalls. That's much nicer for the staff, because when people ring up they can say, I got your letter, thank you for explaining it, I still want to stay. And we have a few people, let me know when you want me to stop talking. Right. We have a few people where my staff say, I just had to hang up and I've got their name, can you please ring them up? I would say there'd be 3 of them. One of them was a member of the local Labor Party having an argument with me saying the changes didn't go through. I said, oh, actually the GP ones got reversed but ours went through. So she's setting me up with a conversation with the local MP and she's dragging me along. So that actually was useful, despite the fact my staff were stressed. And I've had another couple of people that were just very angry that we had changed our billing practices after 20 years. But sometimes people are angry. And then we've had other people who don't actually care, don't remember what my staff told them was the fee, don't care. They turn up at the front desk with a credit card. I don't remember what Malinda said, but she said I've got to fix it up. I want more of those. But at the same time, I'm compassionate for the people that can't afford to pay to see me, and so I've got another optometrist that is part-time at my practice. They're not a brand name, they're not the name on the door, so to speak. At the moment, I'm keeping other practitioners at my practice on bulk billing while I see how it goes, so people have an option of eye care. And this is in a town where there's already 4 practices, so they've got options. They can walk 100 metres and get eye care. But in my practice, we still have 2 options in billing. That may change, but that's the case at the moment.
Okay, thank you. Before we go anywhere else, there's a couple of questions coming in on email, which I'll just ask. Hello, Rosemary, you're listening to this, aren't you? So Rosemary's question is, using Medicare Easy Claim was mentioned quickly earlier in the webinar. Can someone talk about how we get onto it and how we get it set up, please? Anyone use Easy Claim?
Yeah, I do, but I can't remember. That was 7 years ago. Yeah, sorry, that was 7 years ago that we did it. I'm pretty sure we rang up Medicare provider liaison and asked for electronic claiming or something along those lines, and then they put us through to various people.
It's much, much simpler than that now. All you need to do is get a high caps machine. Yep. That's all it is. Okay, I think 4 or 5 of the major banks, the biggest banks, are all already connected. You just need the terminal. It's as simple as that.
And if you are struggling with it at all, there is, in fact, a dedicated Easy Claims team at Medicare who are very accommodating when we've had to ring them recently. So if you want to contact the association office, we can give you those details.
It's in the newsletters.
Oh, it's in the newsletters as well.
Yeah, so if you've got a high caps machine already and you want to turn on Easy Claim, it'll take you about 3 minutes. Yep. And about half an hour to type all the item numbers in.
Just as an add-on, we've got both machines. We've got both a high caps machine that's running through NAB, and we've got the CBA one that we dedicate to the Easy Claim. So that way we're not tying the machine, because pressing 20 buttons to get a claim is very frustrating. So we use one machine to take the payment, and we use the other machine to make the claim. Paying $50 extra a month, but...
Actually, that's a point. We do have 2 high caps machines. Yeah. And I'd check your rate, by the way, Nick.
Well, the CBA ones.
There's another question, one other from Esther.
They're special.
On the email. 2 questions. Patient comes in for eyelash ablation every 2 months or so. Can I charge a 918 every time he comes in?
I would charge a 916, but yeah.
916, new course of attention?
Yep, 916.
916, okay. Question 2, patients come in for a referral to an ophthalmologist. Can I charge Medicare, and if so, what item number?
It depends on how long it takes you to make up your mind what you're referring them for, because you're obliged to put that in the referral, otherwise it's actually not a referral. And that might take you 2 minutes because you saw them 6 months ago and they've still got glaucoma, just like last time. Or they might be new to you, you've never seen them before. Carer tells you that they've got severe dementia and you have no idea what they're actually telling you. You might take an entire consultation to decide why you're referring them to the ophthalmologist. So it will depend.
Back to your you don't know until you've finished it.
Was that the patient actually attending?
Yes.
The reason I asked that question is if the patient, for optometry services, the patient actually has to attend. A doctor, for example, can charge for a telephone consultation, an optometrist cannot.
Someone with... Yes, Joe, I'm coming.
Just to recapitulate, if they come in there and they come in for 2 minutes, but they actually attend you and they sit with you and you write a letter out but you don't do anything else, can you still charge a 10918?
You can, and then if Medicare ever audits that item number, you have to be able to justify it to your colleagues.
Yep, they came into my office and they sat there while I wrote the letter out. That's good enough.
Well, technically speaking, the issue is addressed in the the optometry benefits schedule book, and I think other than both the optometrist and the patient having to be present at the same time, a number of other criteria have to be fulfilled, one of which is a significant clinical examination procedure has to have been conducted. I can't remember the exact words, but something of a clinical nature, other than the patient requesting a referral, has to be carried out. I mean, that could be as simple as you taking a 30-second history, I suppose.
Or observing the nail in their eye.
Yeah, so, but something of a clinical nature has to have been done.
Yeah.
The other thing that I'll say on referrals, and this applies to all practitioners, not just optometrists, you don't have to have the patient attending in order to provide them with a referral. A patient can have a referral, if they've just requested it over the phone. All that's required for you to write a referral is that you have to have turned your mind to the needs of the patient before you write that referral.
Like no visit, no claim.
Well, yeah.
Thank you. Malinda? It's a question to Malinda. Have you found that by going private billing, you've interfered with the retail spend in the front of your store?
1st of January wasn't very far away. And like I said, we have more than one way to procure an eye exam at our practice. So I would say too early to tell at this stage. Oh, are you asking the percentage of conversions? Has that changed? I would say still a bit early to tell. Are we tending to keep the people that are willing to spend and then buy better stuff and losing the people that don't want to buy the cheap stuff? Maybe, but I guess too early to tell at the moment, yeah.
Just a quick question about writing referrals. Is there provision under Medicare for charging fees for collating and typing up referrals for patients? Or is that only for people who need reports and referrals for something outside Medicare service?
There's nothing spelt out in the explanatory notes or the schedule to say that there are fees attached to the writing of a referral, collating the information to write a referral.
And likewise, there's not saying that you can't.
You can't charge when it is included in the schedule. So if you're able to bill something in the schedule, you can't then charge a private fee. So I guess Nick mentioned something just a second ago. We were just pondering if someone phoned up for a referral, didn't want to attend, therefore they're not eligible for the MBS, can you then charge a fee in that scenario?
That's basically what I'm thinking.
Yeah.
You can.
I would say a private fee.
Because there's no item number applicable at that point.
You can in that circumstance, but you can't charge a private fee for making a referral. There's a sort of a basic thing, it's common law aspect really. Basically it comes down to what does the patient expect out of the consultation? What is your contract with the patient? And if a patient comes and you say to them, you've got an eye infection, I'll have to write you a prescription for the drugs. The patient expects to get that prescription. It doesn't have to, that's part of the contract, if you like, with the patient. And so you can't charge extra for the writing of the prescription for medicine, for example. In the same way, if you find something wrong with them, the expectation they have is that you will refer them to someone else that can look after them if you can't. So you can't charge for the referral if they're paying you for a consultation.
Right.
But if they're not paying you for a consultation, you can charge for a referral.
Very often people will, as Nick's case, call up because they've suddenly been informed by the ophthalmologist's office that they're expecting them to come up with a referral from us. We might not have seen them for a whole 12 months, so technically we don't really know what we're putting on that form, except I'm referring Mrs. X for review of their...
Really, Steve made the point that the requirement is that you turn your mind to it. You don't have to examine them, you have to turn your mind to them, and that sort of means you're making some sort of assessment from what they say.
Right.
Is there any impact
by changing the general recalls from 2 to 3 years on professional indemnity insurance?
I wouldn't think so. The insurance policy just says that the policy just says that it covers you for those things that optometrists do.
But in the same light as if a patient was to return after 2 years, you're asking back after 2 years and something goes wrong after 12 months in the old MBS, it's exactly the same situation. So you will recall the patients on what you think is best clinical practice and clinical need, and that's what the MBS advises you to do. Beyond that, if you can justify that this patient needs to come back after 3 years because there's nothing wrong, everything's fine. If something happens in the interim, well then that's just part of it. There's no danger that you'd be held liable for something going wrong with a patient within that recall period.
Can I just make the point that one of the things that's very difficult for us to do is to make the distinction between what constitutes good clinical care and what Medicare will pay for. They are not synonymous. They sometimes coincide, but you make clinical decisions and then Medicare will sometimes pay for those clinical decisions. The two are not inexorably linked. And now going out to a 3-year benefit period, that link is even more tenuous. So, as the panel has said, don't automatically assume that because that benefit period has changed, that anything else has changed. It hasn't. The two are not synonymous.
Joe, just a backtrack question. You passed the comment before Frank was asking about our changes going through, and your answer was that they'd been passed through the Senate. My understanding was that's not quite right. It was changed by regulation, not by a passage through the Senate, and the regulations, my understanding is signed by the Governor-General, and then it sits there for the first 6 days of the new Parliament, which is what's going on now. So it hadn't gone through the Senate. But my question simply was a political one. Can anybody on the panel tell the members gathered here what sort of negotiations went on with the Labor Party and then the minor parties as to were any of those in favour of supporting us as opposed to the government? And in the case of the financial institutions legislation that was rejected in that 6-day period, was there any support amongst any of the parties to support us?
I'm sorry, what you say about the Senate was right. I just abbreviated the thing, but all it required is the regulations were changed. They lay on the table, as they say, for 14 days. If no one objects to them, they're just adopted as law. I'm not employed by the association anymore, so I don't really know what happened politically. Simon might be able to tell you.
I can't comment on that, sorry, no.
You can't comment? I mean, we're the members of the association.
Let me clarify. I'm not aware of sort of the inclinations of the
Let me just
political parties.
While you're talking, let me just see if I can get Genevieve and see if I can get an answer for you, because Genevieve was our national CEO, was obviously deeply involved in those discussions.
I have just one other comment as well. I was never aware that the association, either at a state level or a national level, was pushing for a change where we now have one group who are entitled to consultation more regularly than the rest of the population. I would have thought, and I had some correspondence with the national body, that they acted on the advice they received from the state bodies, but I've been a member of the association for 30 years and I've never seen any correspondence or any discussion that the association was moving from a situation where it felt everybody should be entitled to a comprehensive consultation every 2 years to we're now going to lobby for one group, i.e. the over 65-year-olds, being able to have it every year. And I feel this may have been detrimental to our situation in the long term, because they've now said, okay, well, we'll give them something by giving them over 65s every year, but I strongly disagree that everybody else goes back to 3 years. And I'm very surprised that I've seen nothing from the association asking for discussion from us as the members. We're the fee-paying people. So, I'm sorry? Yeah, I'm a member of the association. This happened after when the budget came out, but I'd never seen anything from the association about it.
Now, can I just say, Timon, did you want to?
When you're ready.
On that, my understanding of what happened was that the federal government decided to change the rebate period to 3 years as a general rule. There were then negotiations by our national office to try and get that back, and the compromise position was, okay, if you're over 65, we'll give you 1 year. But it wasn't that the association has never gone to Canberra and said, we want you to reduce the benefit period. What had happened was the government decided to change it, and then we tried to pull it back, and that's how we got the 1 year back.
If I can just add to what Andrew's saying, the association has never pushed for a 3-year rebatable examination on patients under 65 years of age. This was a federal budget measure that came out, and we heard with the rest of you when that came out. Not entirely sure whether or not we compromised on the 1 year. If memory serves me correct, when the federal budget measures came out in May of 2014, that was already in there. We didn't need to compromise or to get that back. So it was already stated in May 2014 that anyone under 65 would be eligible for a 3-year review, comprehensive eye examination, and anybody 65 or over would get a 1 year review. This was not something that the association ever pushed for or lobbied for.
What about children's vision? Why aren't children put into that 1 year period?
It's a good question, and this question actually came across my desk last week. Andrew had emailed me and said that there was some misconception that children or people with concession card or certain disadvantaged groups were eligible for a 1 year review. As the Medicare schedule reads, it's a blanket rule. Anyone under 65 is eligible for a 3-year review.
Is the association trying to do something about children's vision?
Well, we're trying to do. We're not just trying to do something about children's vision. We've expressed our concern, and we'll continue to express our concern and explain to government that this does not reflect the needs of the public or the needs of the optometrists and our practitioners moving forward. But all we can do is continue to lobby and continue to talk to them, and as soon as we can push for something, we will.
So I understand that a patient doesn't need to present, but if somebody rings, is there a time limit that we're able to write a referral without seeing the patient, or is there a recommended or stated time period? So in our practice, for instance, if somebody rings and wants a referral and we've not seen them for 12 months, we tell them they need to come in so that then we can write new details as required in the referral. But is there anything that states a time limit at all?
So,
no, I think you can do basically whatever you want. So when you say a time limit, you don't mean the length of the referral, you mean...
no, just the time that you have seen the patient proceeding.
It's a judgment call.
Request.
It's a judgment call on your part. I can't recall anything in the Medicare schedule that stipulates what you do in terms of how you advise the patient. It's a judgment call. Just one thing I would say on referrals that is not much talked about, and that is the length of time that a referral is valid for. You're entitled to write on the referral how long it's valid for. So if you have a patient whom you've referred for glaucoma treatment to by their ophthalmologist, they're going to need lifelong care, let's say, from the ophthalmologist. You can write on the referral indefinite, so that means the patient doesn't have to come back to you every year when the ophthalmologist says go see your optometrist to get another referral. Now that may not please the ophthalmologist, obviously, but no, so if you want to annoy them, that's one thing you can do, but just remember that
they just ignore it
on any referral you can write down how long that referral is valid for. It's your call as the referrer.
But keep in mind that it's the patient that suffers in this. It's not right, but ultimately it's the patient that pays the higher fees if you don't write a referral, or they have to go around and find someone else to write it for them.
Just a comment, that indefinite referral clause that I used to use for many years doesn't work. You can write it 100 times, the ophthalmologist will always want another referral in 12 months' time. They don't take any notice of it whatsoever, so it's just an absolute waste of time.
Well, you're perfectly well within your rights to ask your practice staff if somebody says, can I have a new referral? At the phone call level, yeah, it sounds like it's been over a year. I'll book you in with your optometrist, Fred, and they can book them in for a regular consultation or for a review, whatever you've chosen to teach your practice staff to say. It's a decision you're allowed to make. Or you can say, the doctor might be able to do that for you if you call yourself a doctor or not. But how about I take a message, I'll have a chat to him, and I'll work out how long we need to give you in the appointment book. And don't offer over the phone to fax it to them. Take a message, just like we do when we're trying to find if the broken temple is still in stock. Talk to the optometrist and get back to them with the amount of appointment time you want them to have. And you might look at your file and realise they're in a wheelchair and they've got 17 children and they're really ill, and you're going to fax it to them and not charge them anything. But you get to decide that, and you don't have to decide it on the spot. You can teach your staff to give you some buffer time to think about these things.
If the government says that over 65 patients can be billed, bulk billed every 12 months, that implies that it's in the long-term interest of the patient to be seen every 12 months. Does that mean that we are allowed to send them reminder every 12 months or no?
My understanding with reminders is that you have to look at the needs of the patient. It's not the time frame.
Yeah.
I was having this discussion with some colleagues about under 65s. Does that now mean that you shouldn't be calling them every 2 years? You should, same thing.
Yes.
And in the end, it's got nothing to do with it. But we've always taken that as an implication. So John is eligible every 2 years, so the implication is I can imply from that I should remind them every 2 years. So I rang up the association and asked them questions like that. And on their website, they talk about, I think, between the ages of 40 and 65, 2 to 3 years. And we were talking about, well, is there any evidence to back that? And there isn't. Yeah. And there was a fairly recent study done by Professor Taylor in Melbourne, which was suggesting every 5 years would be safe. So you can, if you see little Johnny, 15-year-old, 648 vision, not a single flaw that you can find, what should you recommend that he should return? So I guess what you'll do, like the rest of us, says, well, the next time he's allowed a claim is in 3 years' time, so that sounds about right. So with your 65-year-old, how many 65-year-olds don't have hypertension or signs of numerous diseases or on tons of different medications? So I suspect we will all be saying, Mr. 65-year-old, I would like to see you in 12 months. Mr. 40-year-old, pre-presbyo with not a single problem, I would like to see you in 3 years' time.
I guess the question there as well is, if your recall's already, say, 24 months and practice management software now gives you the option to edit the whole batch of them, do you run that batch edit and swap them all out to 36 months and pull the other ones into 12 months? And can you justify that? Or do you have to look at every individual record before you run that schedule on your database to tidy up your recalls? That's an interesting question.
We've done every single one.
Can I make the point that I really think that automated recalls are a mistake? You really should make the decision on the recall period with each patient at the end of each consultation.
Can I also just reiterate what Andrew was saying, which is that we really need to consider delinking what the Medicare benefit schedule rebate entitlement is to what we believe the best clinical practice and needs of the patients are. So just because the patient's entitled to a review in 3 years or a comprehensive eye examination in 3 years' time, it doesn't mean that may be the best recall period for the patient.
Just again on that topic, it's not exactly Medicare, but in terms of recalls, what we do at the practice, I used to just send out recalls. I used to say to the end of the patient at the end of the consultation, I'd like to see you again in this amount of time, and you'll get a postcard and you'll get a letter. We've gradually been moving over the last few years to pre-booking patients. So the same thing, I'll say to the patient, I'd like to see you in 6 months' time for a pressure test. I book it in, I give them the booking, and I say, if you or I go on holidays, let's ring each other and change it. The patient's owned the next decision-making step in their healthcare. Our no-show rates is pretty good. And the staff remind them 24 hours out again, obviously.
Chairman's prerogative, there's been a couple of questions come up as we've gone through this in the office. There's a couple of odd ones I just wanted to get opinions on. So this one says, about a 10916, the descriptor says, and this applies to a 918 as well, the descriptor says it is a consultation of less than 15 minutes. If I spend more than 15 minutes, can I still bill it? You may not believe how many times we've been asked this. Come on, Steve, this is what would you think if you somehow magically discovered that Nick had spent more than 15 minutes on a 916?
Well, obviously the content of the examination is the critical thing. So, but the short answer is yes. I mean, if you spend 16 minutes or 20 minutes, if the content is not comprehensive and there's no new course of attention, there is a new course of attention, then it's 916 still.
We've had firm advice from the Department of Human Services, from Medicare, that is the correct answer. That even if you spend more than 15 minutes, there's nothing wrong. Unless, of course, the patient is a returning patient and they've come in with a new sign or symptom, in which case it may be a foreign body that you've spent 17 minutes removing, then you would charge a 913 for that.
The question was, what about RTA assessments where people come in and ask you for specific examinations related to their RTA or RMS requirements?
Well, those are rebatable under Medicare, so if that's the question, you can. Yeah.
Then 914.
Well, if it's taking you around 15 minutes, then yeah.
But you can charge a long run if it takes you longer.
I mean, it could be a 918 if
Microphones, please.
Subsequent could be a 918 if it's...
Yeah, but it can be, if it's a complete reassessment, new course of attention, if you can justify that.
Diabetic.
Yeah, diabetic, progressive, 1-4.
So it comes back to the content of the examination, what you feel is required for the appropriate management of that patient. If it's just ticking a bunch of boxes and nothing else, then, and you can do that in 15 minutes, well, that's what it is, a 916.
Just presumably that it's not a commercial license. Yeah.
Second one of my oddities. Simon, this might be one for you. You used to be able to call a hotline to check eligibility for a 900. Does this now apply to the 910, 911?
Sure does, and same number.
And it works?
And it works.
Not that I was doubting, but in the early days, apparently there were some teething problems. All right. They're the scenarios we've had posed to us through the things. Tom, I'm going to come to you.
Great, thanks. Just on the 10916 that we just discussed a couple of minutes ago, if I see a patient for the first time and I rung up and I realise that he's not eligible for a 10900, right? Does anything stop me from charging a 10916 instead of a 10907? So that way I won't reset the clock.
You won't reset either way. 907 doesn't reset the clock.
Yeah. Well, technically a 916 is not a comprehensive examination. So if you've provided a comprehensive examination, then 907 is is the item number. If they
Right, so I have to then charge a 10907 if I've provided a...
Well,
right.
I guess what Medicare would say is if the only reason you're doing a 916 is to avoid restarting the clock,
Correct.
then it's not like a clinical reason that led you to select that item number.
Okay.
So but I mean, obviously people do that, and you know, it doesn't really get monitored because it's hard to tell.
Does a 918 apply to any type of comprehensive examination at all, having seen that patient before?
So I mean, if I understand your question correctly, you're asking, can a 918 be used for a comprehensive examination? The answer is yes. The answer is if the patient has returned within 3 years and they're under 65 and they're not eligible for any other comprehensive item, 912, 3, 4 or 5, then the 918 is, from the advice we've been given, is the item that should be used, the only appropriate item to be used in that instance. Because there is nothing in the 918, the script, to say that it has to be less than 15 minutes. There's no time limit on that at all.
Yeah, that's an important point. I think a lot of people assume that because the benefit associated with a 918 is half that for a comprehensive, that a 918 must refer to a brief consultation in some way. But as Simon has said, there's nothing in the MBS wording that restricts how long a 918 attendance lasts. It could be as little as 30 seconds, or it could be, you know, longer than an hour. There's no time limit. And the content doesn't matter. It can be comprehensive or non-comprehensive. All that is required is for that attendance to be subsequent to a previous one in a course of attention.
Correct. Correct.
So the question was, if you're not bulk billing, you can apply whatever fee to the 918, and the answer is yes, that's true. I think we're drawing to the end. Please, if you've still got a couple of burning questions, feel free to come up. I did try to ring Genevieve, she's not answering, so we might happy to follow that up tomorrow with you. Thank you for coming along. If there are any questions you want to impose on the panel, please do so. If as we go through this, because we're all learning a lot about this as we go, please ring us. If we don't know the answer, we'll get it. As I said, Joe's on the phone, Simon's on the phone. Very happy to assist. Thanks for coming out. Hope it's been of use. And we will be in touch again shortly with something else to fill your Monday nights. Have a good evening. Thank you.